This program is brought to you by Accelero Health Partners. Welcome to the Accelero Advantage Education Series, advanced thinking to keep you ahead of the competition.
As a result of national healthcare reform, there are two outcomes that are inevitable. First, access to care will be expanded, and second, savings will need to occur by having providers more actively involved in delivering care that is evidence-based, coordinated, and cost-effective. Our goal in these payment presentations is to provide you with important information in three key areas: bundled payment models, accountable care organizations, and the transformation from what has mostly been a pay-for-reporting model to a pay-for-performance model. This session will provide background information on accountable care organizations. This table provides an overview of healthcare reform accounting for the costs of providing health coverage to more individuals, as well as some of the areas of additional revenue and spending reductions to offset the cost. Part of these cost reductions are from changes in Medicare payment rates and methodologies over the next 5 years. Two of the most talked about new payment methods are accountable care organizations and bundled payment models. Dr. Elliot Fisher formalized the term ACO. He described the development of partnerships in which there are legal arrangements between hospitals, primary care physicians, specialists, and other providers. The reason to align these providers is to improve healthcare quality by reducing variations in care and slowing the growth of healthcare costs. Accountable care is not a new concept. In fact, it began with health maintenance organizations in the mid-1970s. The primary criticism of the HMO model was that quality at times was sacrificed since cost reduction was the primary goal. There was also a high level of financial risk for the providers. Fully integrated systems such as Kaiser and Geisinger have created their own insurance plans and have proven to be effective in improving quality while reducing costs. While there are multiple models and pilots of accountable care organizations, in this presentation we are going to focus on the Medicare model, since this is projected to have the broadest impact nationally and will most likely be a model that other payers will duplicate in some form. Part of the healthcare reform legislation, the Department of Health and Human Services has been given the mandate to pilot an accountable care model no later than January of 2012. As defined by Medicare, accountable care organizations would manage and coordinate care for a defined group of Medicare beneficiaries. And if certain performance standards are met, the accountable care organization will qualify for additional payments beyond their typical Part A and Part B payments. Medicare has not fully defined the structure of the ACO pilots. However, they have discussed some preliminary requirements that an ACO must have in order to be part of the pilot project. First and foremost, there must be a defined structure and organization of providers, including at the very least a hospital, primary care physicians, and specialty physicians. Having this defined structure will be the greatest challenge and need in forming a successful ACO. This aligned group of providers must have sufficient base of primary care physicians to manage at least 5,000 Medicare patients to be part of the pilot. This is estimated to be a minimum of 15 to 20 primary care physicians. In addition, to be eligible for the pilot project, an ACO must participate for at least 3 years. For an ACO to work successfully, there must be joint decision-making among the providers. Essentially, the organization must have a solid data infrastructure and sufficient IT connectivity to provide the necessary information for care assessment, coordination, and management. The IT requirements will also present a significant challenge to many organizations considering to be part of the pilot program. Finally, for the ACO to be effective, they must have defined processes to promote evidence-based medicine, report on quality and cost measures, and coordinate care. This will most likely require an increase in supportive personnel, such as discharge planners, care managers, and other staff such as health coaches assisting in the coordination of care. As you can see, there is a substantial amount of organization that needs to occur for the formation of an ACO. What is the upside to forming an ACO? In the Medicare pilot, the providers will still receive their Part A and Part B fee-for-service reimbursement. So from that perspective, there is no direct financial risk to providers. The upside is that the ACO can receive additional payments from any savings they create, hence the term shared savings program, if two things occur. First, they need to meet quality performance standards, and second, actual savings need to occur. Let's examine each of these areas. The ACO will need to accurately track performance standards that will be defined by Medicare. These quality standards have not yet been defined, but in all likelihood would include measures in such areas as mortality and morbidity, improvements in function, patient satisfaction, and provider utilization and costs. Most hospitals are currently accustomed to collecting this type of quality information. The challenge for an ACO will be measuring and improving these types of measures across multiple providers for extended episodes of care that will often involve chronic disease processes. If the quality standards are met, then certain financial performance standards must also be met before an ACO receives some of the shared savings. While these guidelines have not been finalized, here's an overview of the defined rules. First, for an ACO to qualify for the shared savings, the actual spending for a defined period of time must be below the baseline spending. The baseline will be calculated based on total expenditures for the defined population for the most recent 3 years. The savings that an ACO would create would come from the efficiency they gain through better coordination of care. A portion of these savings will be passed on to the ACO, and Medicare will retain the remaining amount. Final guidelines as to how these percentages will be distributed and any limits on total shared savings distribution are not finalized at this time. So if the quality and financial targets are not achieved, the ACO will not be penalized in the Medicare model. In other ACO models, this may not be the case, and the ACO members may have greater risk. It is also important to consider that by creating these savings, the ACO will most likely be reducing their Part A and Part B reimbursement, since it's anticipated that the ACO will decrease fee-per-service utilization. So while the shared savings appears to be additional funds, they may be essential to a provider to offset some of their loss of the Part A and Part B reimbursement. Remember that